Okay, good evening all to the 127th session of the weekly huddle. I'm your host Anup, and joining me today is my friend and co-host Praneeth. We both are cardiologists working at KIMS Hospital. Most of you are quite familiar with the Huddle platform. It's an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily clinical practice. Our typical model is case discussion, where we typically bring up a clinical case and then we kind of have a discussion around that, which is both scientific as well as more pragmatic. But once in a while, we do take topics for our discussion, and those topics which are quite relevant for our current clinical discussion. And with that in mind, my today's topic is the COVID quote unquote pandemic or epidemic, whatever you call it. And we are trying to address where are we headed, particularly with reference to India. Basically to work with our discussion, you have heard Dr. Anurag Agrawal. I have put in a brief introduction about him on the WhatsApp group, which I'm sure most of you have already read. Let me remind you, this is not a speaker and audience model where there is one speaker and everybody else has to listen. So I urge any of my attendees, if they have any questions or comments, they can either put it in the chat box or raise your hand or unmute yourself, and you can ask your question and put up your comment. So with that introduction, I will get started. And typically, I ask my colleague Praneeth for his initial impression, but because this is going to be a topic discussion, I will directly go to my guest. And as we are going through the discussion, if any of the questions that come to your mind, please feel free to share it with me or on the group, and we will try to address as many questions as possible. So, Anurag sir, I first would ask to get your view on this whole new COVID pandemic. I know China is suffering, and we partly know the reason. Their zero COVID policy, their vaccines, their whatever efficacy was there, there is all this propaganda and hypothesis going around. The PF7 variant, the XBB variant, some fake news circulating around. If you could just give us an overview of what is the current variant, what is the transmissibility, if we have an RO number by now, and how much we should be scared about it.
Okay. So Anup, one very important thing I'll start with is that there is an effective R number and a real R number. Similarly, there would be an effective lethality as well as a background lethality. So all background numbers are calculated in a naive population. So when you calculate the true R of a virus or the true lethality or the true risks, it assumes a population that is vulnerable and it's age standardized. Now that unfortunately is simply not true anymore. So all the estimates that one gets are heavily dependent on a variety of methodologies which have got progressively biased. So let's quickly on the R number, let's take a different question first. The main reason that COVID-19 pandemic has been so, taking a toll around the world was primarily because of a lack of immunity. And we will come back to this again, so keep that in mind. The R, in terms of the number of people each infected person infects, there are multiple ways of measuring it. But the best estimates were that in the original Wuhan variant that spread, this number was probably only close to 2 or 3. And to put this in context, some of the highest numbers we ever seen are typically for measles, where one person gets infected, you put him into a room with uninfected people, everybody gets infected. By the time a mutation came into the original Wuhan, and this actually, if the Greek lettering symbol had been there, this would have been called alpha back in April of 2020 itself. It was the D614G mutation that now people speak about. This increased the transmissibility to a good degree, and probably the R numbers probably went close to 4. By the time we had Delta, we saw further little increase, but nothing very spectacular. Omicron has led to very, very varying estimates. And the very varying estimates come from the fact that we are calculating Delta to Omicron differences in terms of estimating R, which is the wrong way of doing it. Because all the countries where Delta went, then Omicron went, there was already immunity Delta. So by the time Omicron came around, because of immunity Delta, it looked like the multiple of Omicron was 3 times, 4 times, 5 times higher. More conventional estimates, if one person in the family gets it, how many get it, in what period of time, probably give you an R value of less than 10. It's not probably like 15, but it might be. It's just impossible to calculate. But it is nothing very different between multiple Omicrons. Now, the reason I'm building this up is every time a variant of Omicron comes, people say it is even more transmissible. Let's calculate the RT. And all of them use the same method again. They look at the ability of a new Omicron to spread versus a previous Omicron, because by now Delta is gone. There is no Delta to compare to. And they neglect the fact that the previous Omicron probably recently swept through. So immunity has built up. So some of the gain is artificial. So take XBB. XBB is now dominant in India. Is it because XBB is naturally more transmissible? Maybe not. XBB is simply better at evading immunity. So transmissibility in an immune population can give you a growth advantage that does not actually mean fundamentally greater transmissibility. And that's a very common mistake that is being made even by relatively well-informed people. So this innate transmissibility and immune escape combine to give you an effective transmissibility, and this gets confused, especially when it is calculated as a multiple of previous variants. So right now, the mix around the world is the following. You got XBB and BQ.1 that have the highest immune escape amongst all the Omicrons currently existing. If you were to look at fold reduction on neutralization, which is a nice way of thinking about it, how many fold less effective does your neutralization become compared to, say, Delta? BQ.1 and XBB, most prevalent here, are 20-fold reductions. BF.7 and similar lineages, on the other hand, are 10-fold reduced. 10-fold is also plenty, but 20-fold is, even more than 10-fold. So in very, very immune countries like India, BF.7, BA.5, BA.4, they've all come and disappeared. And only the most transmissible ones make a foothold and slowly grow without actually causing major waves. In America, again, the immunity level is reasonably high between vaccination and the number of infections they have had. So BQ.1 is growing. In the northeast part of America now, the New York, Boston area, XBB, a new variant, has again started growing. And again, what looks like transmissibility is probably just more immune escape. In China, immunity is low. So they have 150 things going on. You put any Omicron in China, it will grow. Immune escape to the level of 10x, 20x barely matters in China, because if your immunity is low, how does it matter whether one has 10x reduction, one has 20x reduction? So you're getting BF.7, so in fact, Chinese CDC put out something 2 days ago, which talks about more than 150 lineages of Omicron have been seen in their sequencing. So yeah, China is a mishmash of every possible Omicron that one can imagine. But the dominant ones, even in China, now that they are starting to see, are BQ.1 starting to rise. Because, as the pandemic progresses, some immunity develops, and the one with the more immune escape has greater potential. But the good news is, when it comes to clinical severity, despite the things floating around, by and large, based on good registries, good clinical data from small countries like Qatar, UK, Israel, pretty much all Omicrons have been similar. So that's roughly where we are. And I'll probably let you get a breath in edgeways before I answer more.
Okay, so I will tell you some of what I understood, and then you please correct me.
Sure.
So BQ1, BF7, XBB, they are all Omicron subvariants, right?
Correct.
Right. And did I hear you correct that XBB is the dominant strain in India right now?
Yes, it's a dominant variant.
And that is based upon the genome sequencing that we have.
Correct.
And Anurag sir, just walk us through what is this genome sequencing, who is doing it? Is the data all over the place, or whatever data we get from India, it's a reliable data as far as genome sequencing is concerned?
So it's a consortium of multiple institutions put together in a label called INSACOG. My former institute was one of the initial leading institutes. The sequencing is same quality as anywhere else in the world, and it's very reliable. What is less good in Indian data compared to data from countries like UK is that we don't have a huge amount of clinical information on every patient because we don't have a national electronic health system that is universal. But we are not unique in this. In fact, most countries have relatively poor data beyond sequencing. US, despite being very much into EMRs, is terrible at this compared to, say, UK or Israel, simply because there is no one national system that has everyone. So yes, Indian sequencing data is fine. XBB comes out of the sequencing. The most recent data from India are actually November samples, end November. So nobody would, well, right now, December must be sequenced. It's not on the website at least. But by and large, it is Omicron. And XBB anywhere in the world, when it goes up, very rarely comes down. So WHO, in fact, had released, this is a statement that we had released a little while ago on BQ.1 and XBB. So as you know, Anup, I chair the advisory group for SARS-CoV-2 viral evolution. So this statement is actually drafted with me. So yeah, this is roughly where we are. The most immune evasive variants are these two. These are the ones that flourish where immunity is high. Where immunity is low, any Omicron can flourish.
Does immune evasion is associated with clinical severity, or those are two completely separate stuff?
In theory, a complete immune evasion would be linked to severity again, but most immune evasion is antibody evasion. The cell-based immunity that more importantly determines severity tends to be relatively well preserved across variants. And that's fundamentally by the nature of how T-cell receptors respond versus antibodies respond. Antibodies have a very tight shape-fitting kind of a thing. So any mutation in critical areas can lead to antibody failing to bind properly, while T-cell receptors are a little bit more prolific.
And is there any signal that is coming from either China or from US that these sub-variants of Omicron or sub-lineages of Omicron, they have different susceptibility to the drugs or the antibodies that we have, or
yes,
for all practical purpose, they're all COVID?
Into the two classes of drugs, right? I mean, one is the antibody type drugs, and one would be the antivirals. As of now, there is no known variant of SARS-CoV-2 with a different response to antivirals. These things tend to be a bit more predictable compared to other things also. Antibody, there is tremendous differences. In fact, as these latest variant comes, most of the antibody cocktails become useless because ultimately most antibodies tend to bind in similar mutations and sites compared to the others. So yeah, I mean, that's been a problem that continuously it keeps on changing. And only about 2 antibodies were left, which were pan-neutralizing until the last time we reviewed in December first week. But none of that typically matters that much in India because our antibody cocktail supply is typically the old one. And the latest ones usually aren't here. And you might actually know more because many of you might be importing them from India. So you guys might have a greater sense of how much antibody cocktails are still being used.
And sir, in India, do we actually do in vitro testing of these antibodies and the COVID viruses that we get to at least get some idea that whether they are neutralizing or not? Do we do an actual test here?
Yes, we do. I mean, so the National Institute of Virology looks at neutralization by sera. The National Institute of Immunology also does the same and looks at T-cell work. Multiple Indian institutions have good capacity to look at ability of natural immunity to respond. But your question is probably about synthetic antibodies. Periodically, those tests are also done, but it's not given a very high priority because that is not really a first-line treatment for India in general anyway. So that's not given as high priority as testing for vaccine sera and post-vaccine sera and boosted sera and all those other things.
So as a clinician, if let's say some antibody cocktail is introduced in India, let's say, I'm sure the pharma companies, they keep saying their drug is the best. Is there some authority where I can ask them, hey, I have this synthetic antibody available. Can you tell me, is it actually going to work on the dominant strain that we have in India right now?
No, there is no place where you'd be able to ask that. So that simply is not the way it is as of now. Many people do argue that because at the time of infusion, they're in pretty high concentrations, little bit of effect would probably still work. But your specific question's answer is no. That given that you had an antibody cocktail and you wanted to know against the most currently circulating variants, what was the distribution of effectiveness? No, you would not be able to get there. At most, you might be able to go to websites like the one by CDC, where there's a page on monoclonals and which antibodies work, which ones don't work. If you wish, I can post that. So
yeah, and I'm gonna look for the same thing, but if you find it sooner than me, then you can post.
I know where it is.
Oh, you know where it is. I'm sure you do. So is it bothersome? So again, the question here is, if XBB is the dominant strain, and we have been talking about, or at least getting this fake news or propaganda about how bad XBB is, and what you are saying is it's literally just an immune evasion of this subvariant. Does that make us feel better that we have XBB around us and nothing bad has happened so far? So XBB is unlikely to cause any badness around us?
Two ways to look at it: acute badness and long-term badness. No. So the good thing that is there is we know that our immunity is so high that only XBB is flourishing, nothing else is able to flourish. We know that even in recent testing, so I think the numbers from today were very, very low positivity. So that it's truly about low infections right now. At least right now, we're not speaking of undetected infections. So when we were in January wave, in my institute, because we were doing RT-PCRs of everyone every week, we pretty much found that within January alone, almost half my institute got infected at some point or the other. So low cases in those times in terms of numbers, absolute numbers, were simply, not most people not recognizing. But right now, test positivity rate is extremely low. There are genuinely very few infections. We have the most immune evasive variant already circulating, and yet there are few infections, which means our immunity is high. That's the good side. So acute severe waves seem unlikely because immunity is high. But there's a bad side to it. The bad side is the only way to get immunity so high is because everybody has been infected probably twice by now. I mean, I don't literally mean everybody, but pretty much most people would be in at least one Delta infection, one Omicron infection by now. The long-term consequences of SARS-CoV-2 infections, and I guess cardiologists are the ones who probably will see a lot of it, or perhaps neurologists, as per the available data, will increase the risks of young strokes, young heart attacks. And I think we're already perhaps starting to see it, but again, you guys would have a better sense, being cardiologists mostly, from what I understand, that perhaps it's already starting to happen. And this was reported by the UK, that risks of young strokes are up by 5 times, risks of young heart attacks are up by 2 times due to COVID infection.
This long complication or the long-term complication of COVID is something that we would like to discuss, and probably I'll get few more clinicians on this forum, and we shall discuss, because this is very relevant, Anurag sir, what you pointed out. We are bombarded with news of these young celebrities or people who are influential dying at early age unexpectedly. I'm sure there are stories in the background which we don't know, but there are few cardiologists in the forum today, and I'm pretty sure each one of us are regularly seeing thrombotic events at younger ages these days. Again, to how much to connect that is something that over the time we will learn, and hopefully I will be able to arrange one discussion around that as well. But Anurag sir, you mentioned about genuine low number of cases. Today, a young guy came to me with influenza-like illness, who is otherwise feeling fine. He said at some point my saturation was going 90 or 89. He actually came to me because the treating physician also suspected coronary artery disease. At some point, he mentioned chest fullness. I thought that was all part of upper respiratory tract infection. That's how he came to me. But you're talking about virus escape. This patient escaped two doctors, one who was treating him first, and the second one was me. None of them tested him for COVID. He had all the signs of ILI, as to speak. So do we genuinely believe that COVID infections are less, or we think that we just got so much used to it that now nobody is sending patients for testing?
Well, as of today, I was looking at earlier, somebody had posted, unfortunately, it's WhatsApp group knowledge, so I don't know how confident I am, but they noted in India the total number of positives, the total number of tests, state distributions. The most, as usual, were Kerala and Delhi, probably where tests were more than many other places. And the percentage of tests that were positive were 0.1%. And assuming that WhatsApp forward to be correct, which I cannot vouch for since I didn't check it myself, a 0.1% test positive rate tells you that it's not lack of testing alone keeping the cases low. Genuinely, the cases must be few. So obviously, in a tertiary place, you tend to see those few that are positive with severe illnesses, right? I mean, so the real point of these ratios comes really from primary practices and all the screening tests done across the place. And airport testing is also giving you these kinds of numbers only. So again, it doesn't seem like it is. So for example, the Delhi airport, they had mentioned in a newspaper article that during when the waves were really occurring, they were getting 4 to 5% of people testing positive who didn't even know they were infected, right? And they mentioned that, barely 3 tests came positive out of 1,000 or something like that in the travelers they did on the first day. So it tells you that it is not hidden and we are not detecting it. It's actually quite low.
And is there any value of, from the authority standpoint, is there any value of continuing genome sequencing for these positives? Because
absolutely. Absolutely. Genome surveillance should continue all the time. Genome surveillance is one of those things that you should ideally be doing in peacetime, so that if war comes, you're ready with knowledge. The lead time of genome sequencing is such that if the war has already started, now you start sequencing, it's not going to help you very much. So you should continuously sequence in between. In fact, the most important time is to sequence in between the waves, not during the waves. During the waves, it's almost always the same thing. It's in between the waves when the diversity comes, the evolution becomes more interesting. And typically that's when people forget.
And is there any suggestion that the BQ1 is going to have potential of creating more trouble? Because my guess is if that is the dominant strain in US, it's only a matter of time before it becomes dominant strain here. Is that correct?
No, they seem to be equivalent. They're both 20x. I think whichever gets in first entrenches itself. If anything, even in US, on the northeast side where BQ.1 was there, XBB is starting to grow compared to BQ.1.
Okay.
And it's not that India never saw BQ.1. India saw some cases of BQ. It just never picked up.
So we did have, like, the BQ1 did make its inroad to India. It's just that we didn't see a burst of it, right?
Yeah, so if you look at the, the how they came around, XBB is a recombinant, and BQ1, if I remember correctly, is a BA.5 derivation, and BA.5 is a BA.2 derivation, and India's main wave in January was BA.2. So it is possible that Indian immunity is slightly better to BQ.1 compared to XBB, which came out of recombination of two completely different Omicrons.
And Anurag sir, before I ask my attendees for their experience with this new COVID, one last question with you before I switch gears. What do you think about our preparedness or our suggestion to patients or colleagues or administrators around us in terms of two things? Number one, should we be upgrading our psychosocial behavior again, like what we were doing in Delta and original Omicron variant in terms of social distancing, canceling our public gatherings like birthday parties or whatnot, universal face masking, and then from the hospital standpoint, upgrading their existing infrastructure so that we can kind of restart the COVID wards and whatnot. Do you think these things are something which can be justified or which can be advised based upon the current knowledge that we have?
So here is my take on it. It's not necessarily a universally agreed upon. Our risk today is the same as it was a week ago or 2 weeks ago or at the beginning of this month. All of us chose a path of living that was appropriate to us at that level of risk, and we would not be wrong by continuing it. So basically, if I had planned to attend a party, I would be going to exactly the same party right now without any problem. But then comes the second part, which is a long-term habit. If you go to Japan, you go to Vietnam, you will see people use masks routinely when in very crowded indoor type of area spaces. It's a good habit, to be honest, this kind of respiratory hygiene. I think there is plenty of bugs floating around, and conscious masking in crowded areas with poor ventilation is something that one should be thinking of as a lifetime habit, not necessarily as a sudden COVID protection strategy. So there's nothing wrong with masking. If anything, advocating for masking where possible in crowded indoor spaces is a good suggestion for multiple things. Then comes, of course, I already said I would not be canceling anything right now. But if I had the option, again, this is generally true, rather than creating huge indoor crowds, if you have a better outdoor option, you would take the option, because winters are the time where ventilation is low and respiratory disease transmission is high. Flu is still out there. I mean, there have been big flu outbreaks also in the world. Many other things are there. So not specifically for COVID, I would say as part of a general thing, focusing on better ventilation, use of mask in appropriate setting, using outdoor settings is all good. Hospitals, I don't think need to worry at this. I don't think they need to worry even looking forward a month, short of a brand new variant coming that is completely different from Omicron. The current immunity will be good enough to prevent a big wave of severe disease. There will be isolated cases, there always will be, but no waves of severe disease that I can foresee.
Anurag sir, I'll switch gears. I'll ask some of my attendees about what they have experienced in the past few weeks in terms of COVID. I'll start with my colleague Praneeth. Praneeth, just in probably less than a minute, if you could share what you are seeing as far as COVID is concerned in your clinical practice.
So far, nothing that I am seeing in my practice enough, predominantly cardiology. So for me, nothing has changed in the last few weeks.
Shankar sir?
We are coming across this acute influenza-like illness attributing to common cold, influenza virus, and COVID-19 as a respiratory syncytial virus. So when we ask the patients to get it done, they are very much reluctant. Sir, ye to nahi hai na, kyun kar rahe? So they are very much reluctant to get it done. Even the agencies also, they are not doing, they have not started doing. But I have not come across in this 1 month period, a patient coming with a positive report. But today's, as Dr. Anurag Agrawal rightly mentioned, today's report, I got it through WhatsApp. The new cases are 188 and the active cases are 3,468 cases now so far. And the total tested are 1,34,995. And the TPR is, as mentioned, alluded to also, the 0.14%. There are no deaths, no new deaths so far. Highest new cases reported from Kerala, Karnataka, Maharashtra, and Delhi.
Thank you, sir. Dr. Vijay Reddy, sir, your comments on what you are seeing in your practice as far as COVID is concerned? Vijay, sir, if you can hear me. If anybody has any opinion or any comments to share or any question for Anurag, sir, before I resume my discussion with sir about this COVID situation. If anybody has got any questions or comments, they can unmute themselves or put it in the chat box. Anurag, sir, I'll switch gears and I'll talk a little bit about the vaccines. But before that, I want to ask you something. Shankar sir mentioned about RSV. We all talk about RSV, particularly in kids and whatnot. Should we be testing people for RSV? I know this is a COVID discussion, but because I have you here, RSV vaccine or RSV disease particularly, is it something that we should be testing in our patients?
See, the future of testing is multiplex. I cannot imagine 5 years from now, we will not be using panel-based testing that simply tests for multiple possibilities that include RSV and SARS-CoV-2 and many others, because a lot of technological jumps have been made in the last few years with so many people working on diagnostics. A lot of this has made these kinds of multiplexing very, very possible. And, so the question effectively is moot because that's the way the tech is going. And every person who introduces a multiplex test will have an advantage. So you take one sample and you test for, 5-10 things at once. And the way Nanopore is coming up with NGS as a diagnostic, it could become completely revolutionary also within the same time frame.
So what you are mentioning is that there is active work going on in this phase, right? This is something which is a realistic future.
Absolutely,
right?
Because testing will become easy. So all these RSV, influenza, it's worth knowing what people have. We very often leave it undiagnosed. And I think within the next 5 years, we will see much, much better tests.
And the second virus, which was mentioned in the discussion so far, that is the flu, influenza. So, I'm sure when you were in US, you probably would be dinged if you wouldn't ask your patient for influenza vaccine.
Yep.
When I was there, it was a pain because you're talking about wound infection and then you will get a ding about not asking flu vaccine. This is something which was never that much promoted in India as to speak. And the COVID kind of reinitiated this concept of adult vaccination. It actually makes it easier for me to now talk to adults about vaccination after COVID than what it was before COVID. Because now at least adults are thinking in this regard that they can also get vaccinated. Up until now, I was thinking that, people typically think vaccination are for kids, at least in India. Do you think we should use this opportunity at a systematic level and we'll get a population level benefit by pushing influenza vaccine as well? Or you think flu is something which is categorically problematic in US only?
No, flu is a problem everywhere. We just don't, our system is not, as well designed to test for these things. And number two, we don't monitor it that much, but there is a flu network. And even within India, they do mention that it's very much there. We also have fewer elderly compared to the others. which is why probably it hasn't caught on. But, India will get older. There is no doubt about it. Life expectancy has risen. Flu certainly exists in India as well. The huge Spanish flu pandemic certainly swept through India. We know that as well. So yeah, I cannot imagine a future in which vaccines for elderly for multiple respiratory viral diseases don't become a part of life.
And do you foresee something like this coming from higher up or a leadership where just like COVID, now there will be a COVID app tracking influenza vaccine also? Do you think something like that can be in pipeline?
No, I don't think that's the way it would be. Again, I think the future is a respiratory spectrum monitoring, not virus by virus. There is too many viruses for this kind of virus-specific network to make sense. There might be a respiratory infection network that contains multiple information on multiple vaccines and multiple tests being done across the country. So it will be a syndromic surveillance kind of a network. Same way, the vaccination network would simply incorporate. It would absorb COVID. COVID could become the bones of the larger system, but you won't have separate one for everything. I don't think so.
Before I go to COVID vaccine as a general, one question that is there in chat box is, are there any distinctive clinical features for these new sub-lineages like XBB or Q1, or pretty much every
whatsoever.
Omicron is same?
None that we know of. It is mostly the immunity that is changing the symptoms in terms of, they're becoming a bit milder now. And of course, Omicron itself was clinically very distinct from the previous ones because of dominant upper respiratory compared to lower respiratory. Although lower respiratory was there, it just was less frequent. But now what we are seeing, the little variations are primarily immune-driven, not variant-driven.
So once and for all, we'll hear it from you, the whole news which has been circulating around that XBB, which does not have any symptom.
Totally
all
false.
this. Totally wrong, right?
Yeah.
That is all right. Okay. Let's come to the COVID vaccination part, which I think is probably the most confusing thing amongst clinicians as well as people who come to us. So it is fair for me to assume that most of the Indian population by now has got one vaccine and most likely a second vaccine as well, a second dose as well. Booster dose, I don't know the numbers, but my guess is the majority have not got a booster dose, but a majority probably got a COVID infection after their second dose. That is just my guess. And Anurag sir, you can give me some numbers around it. What is the role of booster vaccine right now? And if you could guide us a little bit about the options available, which we can tell our patients. And then I will ask you the question about the fourth dose, that is the second booster. But
this answer is really tough because I'll be very honest. The biggest challenge is there is no data, right? In terms of our vaccine efficacies and so on. And the reason is the typical Indian has had at least one vaccine at least one infection and 2 vaccines. So pretty much 3 is a natural count for almost every Indian that goes around. The reason for that is, especially in cities of the type where you and I are, that most of the vaccination drive occurred after the Delta wave. At the time of the Delta wave, total vaccination was probably below 10%, closer to 7% of the population. So which means the majority of the people who got vaccinated got it in the face of previous Delta infections. So even immunity that time came was hybrid immunity. Then, of course, the Omicron, by now from our own labs experiences, some SIRA work that we are doing, probably 60 to 70% of people have been infected by Omicron at some point. And this is, I'm only speaking until about April, May in Delhi. This could be a little different, but I would imagine it's similar for the country by now. So the value of the third dose in India is primarily as a precaution, just in case a vulnerable elderly person has not been infected And we know that 2 doses of some vaccines are clearly ineffective in reducing even severe disease in elderly. And this in itself is a reasonably controversial topic. But Chinese data from the outbreaks in Singapore and Hong Kong, Chinese vaccine data from Singapore and Hong Kong show that in people greater than 80 years, the effectiveness against severe disease of killed virus vaccine was only 67%, but became closer to 90 after the 3rd dose. This is Hong Kong data. In Singapore, even after the 3rd dose, the effectiveness against severe disease was only 70-75%. So there is some challenge there. And this is for people greater than 80. For people less than 80, people less than 60, it didn't really matter which vaccine you took. As long as you took 2 doses, severe disease was well preserved. So this is roughly where we are. In India, the choice of vaccines don't matter very much. Complete vaccination is the most important. For elderly people, definitely the people above 80 and probably the people above 60, the 3rd dose probably adds benefit, particularly if you have not been infected. And since we don't really know the infection status of people, it makes sense to use the 3rd dose for at least all elderly and even the highly comorbid and high risk. So that's roughly where we are in the sense of precaution. But I will add one last thing on this. I really don't think that we have used our protein subunit vaccines enough, because they were the ideal boosters based on whatever data existed internationally. I'll stop here.
So the protein subunit you're talking about, that I believe Novavax or something which was there, right?
Yeah, Covovax and Corbevax. They were compared to the adenoviral vector vaccine and the killed virus vaccines. They were by far the better boosters.
So if, let's say, if somebody has to get a booster dose, is there any data in your opinion to support that no matter what was the 1st and 2nd dose, a protein subunit based vaccine is probably the way to go?
Yes, there is a nice Lancet paper looking at both cellular immunity as well as antibody response jump. And clearly protein subunit was superior to both adenovirus vector as well as killed virus. It was not Covaxin. It was a different killed virus. And it was almost as strong as mRNA vaccines in that particular paper. And more than that, one does not know. It was not a vaccine efficacy trial. It was only a, boosting of immunity, blood assays kind of trial. And only data we have for vaccine efficacy with or without boosting comes from abroad, comes from mRNA vaccines, and a little bit of ChAdOx, the adenoviral vector. And we can't really extrapolate that to India because India is so different in terms of the natural immunity by now. So I would not want to do that.
Just so that we clarify for our listeners as well. So the adenovirus, the adeno vector-based vaccine is our Covishield in India, right? Because we're talking about Indian context.
Yes, yes.
The killed virus-based vaccine for India is the Covaxin.
Correct.
And the protein subunit is the Corbavax and the Covovax that you mentioned.
Correct.
And it is reasonable to assume that majority of Indians either got vaccinated with Covishield or with Covaxin, or with a combination of Covishield and Covaxin. And in all 3 situations, the Lancet paper would suggest that using a protein subunit will probably be a better option.
Absolutely.
And the mRNA vaccine is your Pfizer, which to my understanding, and correct me sir if I'm wrong, we don't have access in India so far, right? For the mRNA vaccine.
We don't. And remember now the current generation of vaccines is the bivalent vaccines that include Omicron. So we don't have access to those. There is a nice New England paper showing that bivalent vaccines will give you better protection against Omicron. But again, none of that is very relevant to India, I'll be very honest. When almost everybody is infected, and natural immunity is so high, I don't think it matters at this point.
I'll go back and get your thoughts on when you were saying age more than 60 or age more than 80, particularly those who are not infected with COVID. There is some role of using a booster dose there. Is there a role of actually checking their serum level and serum level of IgG antibody and then giving a booster, those whose IgG is less, or you think that's a non-scientific way of doing it?
That's a pretty scientific way of doing it. But to do this at population scale is very hard. So for national programs, it's not going to work. But for individual doctors to do it, you can detect infection very simply in a person who has not received Covaxin by looking at anti-nucleocapsid antibody.
Who has not received, you have to repeat that again, I didn't catch you. So who have not received a Covaxin?
Yeah, because anti-nucleocapsid antibody can only be generated by infection if your vaccine did not contain the whole virus.
I see. And that antibody testing is available in India?
Oh, yes, we use it quite frequently. So this is how I advise people, whom I don't have to worry about national policy, but who I'm advising. So I tend to get an anti-nucleocapsid antibody done. For me, my lab used to do it, so I didn't have to send it out anywhere. And then use it to kind of tune my advice.
Okay. And then the last question before I let you go, I know you have a second session coming up. There was this discussion, I believe, and IMA had a meeting with the health minister, I believe, a few days ago, and there was some thought that healthcare providers should get a fourth dose, that is second booster, because their third dose was more than a year ago and the immunity is waning. What is your thought on that?
My thought is that most healthcare workers got Omicron after their third dose anyway. And there is not really much point. I just don't see the point. Plus, I don't like the idea of 3 adenoviral vector. The supply of protein subunit has not been large enough to, be the third dose for most people. And there is, unless you keep changing your antigen, there is a huge risk now. There's data not yet published that may indicate that a third dose or a fourth dose might bias you towards more Omicron reinfections because your body starts responding to the old antigen even when faced with a new antigen. So I would really, really hold off on getting a fourth dose of the old antigen effectively.
And sir, this intranasal vaccine, it's a very new thing in the market. I don't know if you would have any insider information.
It's an adenoviral vector vaccine. I hope they included the Omicron, but so little detail about it is available that I'm not able to make sure, because adenovirus DNA vaccine should have been possible to change the construct to an Omicron. It's not as difficult as growing the whole Omicron and creating new whole virus vaccines. One hopes so, but if they had done it, they would have certainly said it. My experience in life is if you're imagining a positive thing, and if whatever you are paying for does not say it has it, it probably does not have it. Very few people fail to advertise a good thing they have done.
Thank you, Anurag, sir. Yeah, it is 7:56. You have to join another session.
Thank you.
Yeah, sir, before you leave, I have Somaraju sir here in the attendees. He is probably one of the senior most cardiologists at
Pleasure to meet you, sir. Pleasure to meet you.
Somaraju sir, your comment on the current COVID aspect that we are having?
Actually, was it 7 o'clock or 8 o'clock today?
Sir, today we did it at 7 o'clock because
I didn't know that. Actually, I just logged in. Sorry, it's my mistake.
Sure.
Thank you very much, sir. It's a pleasure and honor to meet somebody like you.
Pleasure to meet you, sir.
Yeah, ordinary, simple doctors, and we
are all ordinary, simple doctors. Pleasure to meet you. It's all mine.
Having said that, I just want to, if it is irrelevant, you can ignore it. But I just wanted to ask you, we have a concept called, in medicine and science, we have a concept called causes of causes. The causes of causes for COVID to me is, apart from global warming and all those things, humans did on Earth and dealt with themselves and environment and animals around, etc. Suppose I say the causes of causes in COVID is the food habits of one of the major countries in the world. Unless that changes, it's not going to stop. Some more things will come. Please tell me. If it is a very ignorant question, please ignore it.
No, sir, nothing ignorant. I think everything interacts with everything. And certainly our dietary choices will affect our risk. But yes, I mean, these are part of much larger, bigger problems, global warming, habitat erosions. So yes, it deserves much, much more thought if we want to completely eradicate these problems.
Directly, sir, the Chinese food habits.
So I think change in food habits can change risk a little, but fundamental risk does not change in something that one has no immunity to. So that's roughly my thought. But thank you so much. I need to now log out for another meeting. Thank you all.
Anurag sir, thank you so much. I'll chat with you offline after
My
this.
pleasure.
Thank you so much. Thank you. Praneeth, closing comments for today's discussion.
Yeah, it was a very enlightening discussion. Firstly, it is reassuring that COVID is not going to be that much problem. It is reassuring to know that the so-called vaccination and infections that we all had knowingly or unknowingly, and the immunity that we got. Yes, infections are going to be there, but probably lethality is not going to be there. So that scary part which we had was we are not going to face that same situation. So I think we should not get panicked that somebody is getting infected. Hopefully it will be like that so-called third wave where people will have upper respiratory tract infections. Cases will be there, but no overloading of hospitals, no fatalities. So that is reassuring. And I believe vaccines will also be rolled out soon. And probably because of the same notion that we are all infected or vaccinated, vaccines are again not for everybody, but those vulnerable population we can suggest them to take, particularly maybe 65, 70 plus, or somebody who is having comorbidities should be recommended vaccination, and each and every person should take into consideration their risk and make a decision on their vaccination. But it's very thought-provoking. A lot to know about the way we are looking at these diseases and the way India is progressing in terms of making an impact on a global scale as well. So it was very good discussion that we had today.
And before I close, just one request to my attendees. One of the discussion that happened in the last 1 hour was relating to the protein subunit vaccine. And we are quite aware that the supply chain of the protein subunit vaccine has not yet been well established, as in not every hospital or every pharmacy stocks it. So because most of the attendees are in Hyderabad only, if you do have contacts, or if you do have information on where these protein subunit vaccines are available, if you could just pass it on the WhatsApp in real time, so that in case if we do have patients or anybody who is looking for such protein subunit vaccine, now since we know that it has a role to act as a booster vaccine, please share it with us so that we can pass it on to other people as well. I sincerely thank all of you for attending today and listening to Anurag sir. And we could have discussed even more, but he had to leave. But I will put this discussion on YouTube in the next maybe a day or two. So if you want to revise, or if any of your colleagues want to listen to, they can browse that. Thank you again, and we will see you next Wednesday with another session of the Weekly Huddle. Good night, guys.